Very good morning and congratulations to all of you, those organizing this type of event. आप लोग ऐसा. So this topic should come after the airway management and oxygenation ventilation. How much a nursing officer should know and can contribute. In India, everybody is doctor and everybody knows the CPR. But how many we are saving? How the system is helping you and me and other doctors? Another question. So system is different thing, but definitely how we can help each other. I always teaches this. I am teaching for more than 15 years, more than 7,000 doctor nurses I have trained with all of your blessings. But how system helps is a question. Out of hospital cardiac arrest की बात करें तो there are mostly it is cardiac causes in adult. MI, arrhythmia. In hospital cardiac arrest की बात करें जहां पे we serve. We are serving in super duper tertiary referral research institute, and patients are sick patients with 1 or 2 organ failure. And these patients usually in hospital, the problem is respiratory failure, 1 organ damage, even kidney, liver, whatever damage is there that can affect our lung, our heart, and ultimately leading to decreased oxygen level in the blood and brain. So majority of these events occur around us, and how much we recognize and who will recognize is a question. Who will recognize? Doctor is 24/7, 365 around the patients. They come and take rounds, round and round and round. Who are there? You people. You are the workforce. So this 1 week, my Mosi is there. Your CNO is my Mosi. Because our relation when I was resident, she used to help us in doing work in wards. She was ward in charge that time, but now she is in charge of whole SGPGI nursings officers, and it's really proud for me that my Mosi is CNO now. So we should know that what adverse event is happening and how it is identified. And if identified, how we are able to manage it. So whether our nurses, those are selected, they have been given training to identify, to manage. Because this type of lecture is going to do nothing. This is theory. You have already read in your GNMA and BSc, and it doesn't solve. It only sensitizes. So मैं इसको कहता हूं दिमाग में खुजली मचाइए और आगे बढ़िए. So for me, the topic upper and lower airway. The upper airway we know up to larynx. Below the vocal cord, the lower airway. And we should able to manage upper and lower airway, how we can help during resuscitation. The primary aim of airway management during CPR is to facilitate oxygen to the lungs, to blood, to the cell. Because life is flow of oxygen. And secondary purpose, airway can help in prevent of aspiration and contamination. So aspiration, those patients who are unconscious, drowsy, altered sensorium, they get 40% patient get aspirated in higher centers. Those during transport, they should not be transported unconscious patient without intubation, without trach tube. So what we are doing, compare it. This is worldwide practice. No inter-hospital transfer, no in the hospital transfer. Though hospital Gorakhpur to Lucknow, sick patient, unstable patient, not without intubation. From that transplant building to that old hospital, this building, unstable sick patient, not without intubation. And how much facility we having in our OPD, 10,000 patient coming in every day. So those administrators are here and they are listening. So my topic is suggestion, it's challenge for them to achieve. The approach in BLS is when you find a uncautious patient who is unresponsive. Patient is uncautious, we don't know. Heart is working, respiration is there or not. Okay. How we can know? How we can know? Only after assessing that patient. So we should approach that patient, whether it's ward, whether in emergency, whether in ICU, and see the response. If patient is not responding, we don't know the heart is working or respiration is ongoing. Then simple thing, we check the, what we check? Which pulse? Central, either carotid or femoral. So that pulse tells the heart is working. And respiration, chest rise. So if these three things is not there, we will immediately start. Very good. High quality chest compression. So never do CPR and never do only chest compression. Do high quality CPR and do high quality chest compression, because whatever the doctors and nurses are doing for last 15 years, I am doing this thing. 6,000-7,000. 10% are not doing rightly. Okay. So the chance of survival, if you are in your family is a patient, is 100% or less than that. So question, and if you are doing CPR, is CPR is with defibrillation or without defibrillation? Any CPR not possible without defibrillator. And how much availability and you are confident that you can defibrillate. If you are confident, we are in safe hand for each other, even for each other. If patient is cautious but unstable, unstable means unstable ABCD, then we should do the ACLS survey. So BLS survey we do when patient is uncautious, maybe cardiac arrest, but patient is unstable means there is response is there, heart is working, respiration is, but not properly. Blood pressure less than 90, saturation less than 90, this all unstable patient, drowsy. Okay, so yes, our patient will come in for ACLS survey. So ACLS survey is further divided into primary assessment, where we identify unstable ABCD and manage ABCD. So A is coming in both way, whether we are doing BLS or whether we are doing ACLS. So I hope it is clear that ACLS is not CPR. ACLS is done when patient is coming back from the BLS or patient is awake but unstable. Okay, thank you. So you know that in BLS survey, you are checking response, you are calling, activating code blue and starting high quality chest compression, then you are always trying to arrange defibrillator and do defibrillation as much as possible. How much bed we have? 1,200, 1,400. How much defibrillator we have? What is the accessibility of defibrillator? How much time it will take to come and use in your ward, in the gallery, in the OT, in the ICU, in your OPD? How much? We make things on the paper, meeting, tea, discussion, sign, okay, bye-bye, tata. ACLS surveys also start with the A. So A and B, airway, whenever we will deal with airway, we will manage breathing. My boss who told me airway management in Israel, he told, whenever you intubate, ventilate. Intubation is nothing. So what is life if we say? What is life? Life is same for everybody. Getting job, getting money, getting honey. No. Life is unobstructed patent airway. Allowing ventilation means oxygen from atmosphere to cell level, from cell CO2 to the out, and your beautiful heart, let it circulate to all vital organs. Is it different? Let it stop for 2 minutes. अगर 2 मिनट बंद कर दे तो यही जिंदगी है. जिंदगी, this is life, and this is for patient, this is for me, this is for my family. So life ABC वही है, airway, breathing, circulation. But when life stops, then comes CAB. Because airway breathing takes time to manage. Who are trained, who are confident. I am doing first time intubation, boss, let me do the intubation. So intubation is very skilled procedure. Even doctors like me who are anesthetists get failed every day in OT. So for last 20 years, if I am doing only one procedure and still I am saying very difficult. So you can understand how much difficult for others doctor and others paramedic and nurse. If you are not trained, if you are not practicing, अगर घर में दाल ही नहीं बनाई है बहुत 20 साल से, तो सोचिए दाल कैसी बनाएंगे आप. देखिए, it's very important to be on practical, because you will save my life and I will save your life one day. And it will be saved only when India's life is saved with the God grace only. How much good human and how much pray I do. Because system, no system, low system. So you know that during CPR, you check response and response is scene is safe. In hospital, scene is safe. Don't take care of scene. We have to act. So a patient unresponsive, scene is safe. In hospital, you check response, no response, you check pulse and respiration. If no pulse is there, but no respiration, what is this? She is sleeping. नाश्ता करा दिया आप लोगों ने? So if pulse is there but no respiration, it is only respiratory arrest or respiratory failure. Pediatric elder mostly lie here. And if their respiration is not managed, means airway and breathing is not managed, they will go in cardiac arrest. All patients are not cardiac, even in hospital. In this hospital, 30 bed are in cardiology, 20 bed may be in ICU, 50 bed. But why the people are having cardiac arrest in this hospital, in any hospital? One organ affect other organ. So here when respiratory arrest or respiratory failure is there, we should know how to manage. If respiratory arrest means no respiration, we will try to manage airway, try to ventilate. Okay. So if no pulse, no respiration, then it is cardiac arrest. And that will be taken by my friend Ram Naresh. Okay. So always we have to check response. Patient unresponsive, then it is very important to call, because in India ego, meri shift, teri shift, khatam, main chali, ma chali. And who respond timely on, who teaches doctors and nurses that you have to respond in emergency and act and help each other. Everybody is doing its own duty. So alone you can't do anything, because I am not God that I do defibrillator, intubation, How much time we have to save life? मैगी खाइए, कितनी देर में बनती है ना? बनती नहीं है, वो टीवी में ऐड आता है 2 मिनट, बनती तो 10 मिनट में नहीं है. So we need help, code blue, for getting ACLS team, for getting trained BLS team, for getting defibrillator, for getting cardiac drugs, for getting intubation. Which ward has everything ready? 30 seconds, everything will be there. इस सोचो है या हवा में. So response time कब चेक किया हमने? ड्रिल कब करी? What is the standard response time of your hospital, your ward, your different area? पता नहीं. So after activating, so check response 10 seconds, no response, you activate code blue. Code blue सबको समझ में आता है, मरीज को भी समझ में आता है, बेड के किनारे जो बटन है वो दबाना, लेकिन है कहां? ये तो ब्लू ड्रेस दिखती है मुझे तो पीजीआई में, बस बटन ना है. इट्स ऑलवेज बेटर. हम अपने घर में क्या करते हैं? हर कमी को पूरा करते हैं. सो ब्रीदिंग एंड पल्स 10 सेकंड में चेक करना, एंड वी हैव टू स्टार्ट हाई क्वालिटी चेस्ट कंप्रेशन. अब कंप्रेशन अगर आपने कर लिए एंड पेशेंट का हार्ट आपने शुरू कर दिया, देन इट्स वेरी इंपॉर्टेंट, because chest compression only CPR is for out of hospital. In hospital अगर आपने ऑक्सीजन कितनी देर रहेगी अंदर जो आप खाली चेस्ट कंप्रेशन करो? So getting the maximum great output to anyone who is come or having cardiac arrest, we have to do everything. Everything मतलब BLS never saves life. It only gives time to start ACLS and start your system to identify what is the cause of cardiac arrest and treat that cause. Only then the chances. How much chance in India? How much chance outside country? How much chance outside country can you predict? 0 to 25. American standard, where everybody knows, the even nurse, doctor, everybody. It's not I am cardiologist or anesthetist or biochemist. Everybody same course. Every year assessment. Patient not revived. Why not revived is a big question. Everyday discussion after CPR. It's not only DCBC. A question: why patient not revived? Debriefing. My shift is over. Open air. Doctor ka bhi hai. How to open air? We know that tongue obstruct 90% airways. But how tongue obstruct? Do we have that lizard tongue that comes out and go in? How the tongue obstruct? वही तो कह रहा हूं, how it falls back. It's like posterior 1/2 tongue, it has lot of muscles. When our consciousness goes down, it covers the glottis. It forces the epiglottis to cover the glottis. It don't fall back, it fall on the epiglottis. So what we do, we should know that simple maneuver by hand, we can open the airway, because we can align these 3 axes. By how? Yeah. Head tilt, chin lift, and jaw thrust. Triple maneuver, but jaw thrust to be done only in. So when trauma, patient with trauma history coming, then only jaw thrust. And jaw thrust, how to do it? So this is simple airway that is getting obstructed. Okay, epiglottis coming on the glottis. And when you do this head tilt chin lift, simple thing. So whether we are doing this thing or we are getting panic, who, hey, Allah, or CPR start get delayed because we are distracted. No SOP. SOPs, you have to reach 8 a.m. to CNO office and sign. SOP. It happens. Whether it can be delayed or whether it can be avoided. So why? Because SOP. And only nurses say good morning. No doctors. Why? Because very good thing. It's very good thing, but why doctors are not saying good morning to each other and to my nurses? It's bad thing. So many things I say. So jaw thrust only in trauma victim when there is history of trauma. Otherwise, head tilt chin lift will deviate tongues from epiglottis to or glottis, and glottic opening will be there. And in trauma, we have to do one more thing is manual inline stabilization. है ना, ठीक है? So if this is respiratory arrest or there is no respiration or even cardiac arrest, high quality chest compression is ongoing, we give 2 breaths, and these breaths are rescue breath. What is this type breath? Rescue means we are rescuing life. So 1 breath, 1 second key, whether you are giving mouth to mouth, mouth to nose, or by how many of you will give mouth to mouth respiration in any scenario? Nobody will give. And should not be given. Good boss. At home we can give. At home. Our love, our siblings, our friend, our family. But definitely in patient care, we should have a barrier device. Aim is only visual chest rise, not saturation. Okay. And don't waste much time if 2 breaths you have given in 2 seconds, because what is the aim? Not airway breathing, because it takes time. It deviates you from high quality chest compression if you are alone. And we need team. Team मतलब BLS, for doing BLS कितने लोग चाहिए? अगर बहुत अच्छा BLS करना तो 3 लोग चाहिए. एक एयरवे ब्रीदिंग, दूसरा हाई क्वालिटी चेस्ट कंप्रेशन, तीसरा डिफिब्रिलेटर यूज करे. सो कितने समय 3 लोग होते हैं? तो माउथ टू बैरियर डिवाइस, पॉकेट मास्क कितने कोई पॉकेट में है? दूसरा बम्बू, that we say ambu. Bag mask, very important even for those doctors who are not anesthetists, and most important for nursing care. The only device that you can help with your patient while managing airway breathing is butt. When you are single rescuer, 1 person, you will do pocket mask use, because you are using from one of the patient side. You will give 30 compression and 2 breathing, this ratio to be maintained. Always, always, always try to use this oro or nasopharyngeal airway, because that helps in making patent airway from mouth opening to the glottis, and it will improve your ventilation. No doctor is using. I always say, use whether we are doing ambu or you are doing mask ventilation before intubation, but this is the device that should be used, because it opens airway, it gives a track from here to the glottis, and your ventilation will be easy and effective. Okay, so this device everybody know, but how many of you are using with the reservoir bag and 15-liter oxygen is a big question in India. Everybody, because this is when I came for resident training in 2005, I thought, every patient has a new ambu, and ambu is available freely in PGI, because it is 5,000 cost. That you are using it 3,000 to 5,000. One ambu, 1,000 of patients I have used in my training. Only one ambu, no sterilization. So this to be used if in patient to be sterilized clean. Are you doing? People are sleeping. Very good. Achhi story sunata hu na. So how many of you are who will do clean? Who will clean it? Doctors are God. They don't clean. So who will help the God? Angels. You angels. I am anesthetist. Nobody give credit to me. No problem. Same like you. But we should do work. And we are doing work. That's good thing. So this ambu not to be used without oxygen port, oxygen supply 10 to 15 liter, because without oxygen, without reservoir bag, its efficiency is 40 to 60%. If you are using with reservoir bag with oxygen 15 liter, efficiency is 90 to 100% oxygen. It is equivalent to intubation. I am not saying research. I never show this research faltu thing, but in emergency, in out of hospital, in hospital, whether you do bag mask or intubate, equal output. So for managing airway during CPR, bag mask is the best thing that anybody can do. And success rate is high if you are using oral or nasal airway with oxygen with reservoir. सोचो क्या आपके अंबू में ये लगा है कि वो खाली बम्बू है? वो निकालते समय बैग से जब निकालते हैं पैकिंग में से तभी वहां छोड़ दिया, फेंक दिया जाता है। आपके साथ जो है वो बहुत ज्ञानी है, मैं आपको ज्ञान दे रहा हूं। So whether you are one rescuer or two rescuer, you are using bag mask or ambu, the ratio will be 30:2 breathing. But when this ratio stops or not to be done, who will tell? When this ratio stops to be followed, कब नहीं follow करना है? फिर तो कोई दिक्कत ही नहीं है। Good. So if you have a cardiac arrest, my friend, I am exhausted, I am doing CPR on you. How much time you want to I do CPR on you? Or anybody of you, those are sitting here, if having cardiac arrest, how much time I should give you for revive or do CPR? Till I survive. But what about patient? So I say this ratio is till we are doing BLS. When we are coming from BLS to ACLS, or my patient is recovered, or if not recovered, till 20 minutes at least we can continue CPR without advanced airway, without intubation. Okay. So 30:2 5 cycle, it takes 2 minutes. Essay at least 10 times you can do this 5 cycles. So when you move from BLS to ACLS, definitely what is important, advanced or basic? Advanced or basic? So basic is always to be initiated by the paramedic nurses, those are at bedside. So if you are right, then the doctor will get chance or the patient will get chance. If you are not doing right, and your system is not providing you what to be done, system, machines, drugs, resuscitation cart should be on the wheels, 30 seconds it should be besides the patients, any area. So the building will only become strong or will make when the foundation is there. So what is difference in basic or advanced while airway breathing? So basic airway, triple maneuver, use of oronasopharyngeal airway, and use oxygen as much as possible and when available during CPR. So in BLS, we are doing either pocket mask or bag mask ventilation. In advanced or ACLS, it is either using of supraglottic device, that is called advanced airway, or intubation. So intubation comes later on. It is not needed to start CPR. Or even doctors have bhranti, na? Call anesthetist for CPR. Anesthetist is Superman. It will come in 30 seconds. उड़ के आ जाएगा. So this is advanced airway. All paramedic nurses should know how to use this device because it doesn't need laryngoscope and skill. Even bad boy can put this. So definitive airways, endotracheal intubation, when you are putting cuffed endotracheal tube below the vocal cord. So intubation is not needed to start CPR, not needed to maintain CPR. Only patients, when patient is chance of revival and ACLS team has come and that in take over, then only intubation after 20 minutes is indicated. Many care literature. Because intubation हमेशा आपको डिस्ट्रैक्ट करता है, वह आपका चेस्ट कंप्रेशन को रोकता है जब आप इफेक्टिव चेस्ट, आपका डिफिब्रिलेशन को डिले करता है. Even in out of hospital, people are in different hospital, they are very fond of intubation is CPR. No, intubation is not CPR. Bag mask ventilation or LMA is very good to manage airway and breathing. And once you have put LMA or intubation, now the respiratory rate will not be 30:2. The ratio stops. Now the ratio of chest compression will be same. Ram Naresh ji batayenge, and now breathing will be one breathing every 6 seconds. Means in a minute 10 to 12 breaths only. Do not hyperventilate and check if you have intubated. You know how to check it, and by seeing ETCO2, how to check it. कितनी जगह है? And ETCO2 is equal to cardiac output during CPR. As cardiac output improves, because you know cardiac output is 4 to 5 liter, the ETCO2 will come out. So minimum 10, normal value is 35 to 45. Minimum 10 is needed when you are doing high quality chest compression. If your compression is good, the ETCO2 that tells the effective CPR, even effective CPR, effective ventilation, to high, more than 10. So, my dear friends, take home message is this: airway management during CPR, we want to have an open, patent, unobstructed airway that allow effective ventilation, and ventilation is CO2 to the tissue cell and oxygen to the tissue and CO2 out from the tissue. Use high flow. High flow means 10 to 15 liter oxygen. Minimum when the patient is sick and having saturation less than 90%. How much you people are using and how much is taught to you during your courses? कितना use करेंगे? Whenever saturation is less than 90 or any sick patient. कहने दो किसी को जो भी कह रहे. ठीक. CAB is most important to follow. मतलब chest compression, chest compression, chest compression with airway breathing is the best. मोमोज खाए आपने? चटनी ना हो तो चटनी is airway breathing. Do not delay high quality chest compression or defibrillation for fond of आज intubate हम करते सर. Not needed to see heroic on patients. Mannequin is there. Intubation is not must to start CPR and continue CPR. Effective bag mask ventilation with oral nasal airway, with और वो कैसा with reservoir bag पीछे जो लगा है 10 to 50 liter oxygen or LMA is more than enough to revive any patients. So thank you so much.